Pancreatic mass, duodenal mass.
Yes, perfect. Okay, so this is the pancreas. We come down, pancreatic duct, bile duct, and then we have this mass. What's your differential? What do you think it is?
Looks like solid cystic. It's in the groove.
Yes.
Solid cystic.
I'll show you the T2.
Okay, two things come to mind. Solid cystic. So one can be schwannoma, one can be Brunner's gland.
Okay. There's three things to me that come to mind in this area. So one is neuroendocrine, because it can be a lymph node or pancreatic neuroendocrine. The other is a gist, because it could be a duodenal gist. And the other that I've seen here is paraganglioma. So I'll just tell you what it was. This was a neuroendocrine tumor that was exophytic. It was a pancreatic neuroendocrine that was like exophytic from the pancreas. If it is a gist, by the way, or like any of them, you have to kind of look at how far it is from the ampulla to see if they can, possibly not do a Whipple, or if it's involving the ampulla, if they have to do a Whipple. So you can see here how it's basically hanging off the edge of the pancreas here. So they actually enucleated this lesion. And then, oops, now I did it. Let's see. 1 second, I'm just going to pause for a sec. So it was enucleated. Oh, sorry, this was the original. Let me go to the follow-up that I wanted to show you. They came for follow-ups for several years, and then we started seeing like a tiny little lesion here. I think it's really it was a very impressive kind of pickup. I'll show you on the pre-contrast. There it was. So yeah, you can see it definitely in the pre-contrast. It's standing out next to the T1 hyperintense pancreas. And then they ended up getting a dotatate scan where it was very avid. Right there. And then we were reading the follow-up. One of my colleagues was reading the follow-up, and this is what it looked like. And they were like, okay, what is this? Like it went from like being not very bright to having this cystic look to it. It was their cystic degeneration of this neuroendocrine recurrence, etc. And turns out that this had been endoscopically radiofrequency ablated. And so this was the post radiofrequency ablation appearance. And there was no internal enhancement, so it was all treated. So it was something, so there it is. I did not know that our endoscopists were doing this, but basically if there's a small little lesion, they can go through the stomach or duodenum and then ablate it radiofrequency wise. So, and this was the subtraction. Isn't that cool?
Yep.
This is a post-liver transplant. Lots happening here. I'll just highlight what I thought. This was a really great call from my colleague. This is the arterial phase, and they noted that there was early arterial filling of the left hepatic vein. And then this is the delayed, and it becomes ISO, but because of the early filling, they had suggested that there could be some kind of like fistula happening there. And then so the patient went on to get angiography, and there was indeed a little communication here, and they embolized it, and it really good outcome after embolization, and then it resolved. So just a really
Wait, can
great
you show
pickup.
that? Yeah, show this one again. Just like scroll through it slowly.
Oh, you're looking for the actual.
No, I was just kind of so was the communication between the artery and the
vein. So it must have been somewhere like right here.
Got it. Because on the angio it looks more central, but yeah, I didn't. Yeah,
Or like, oh, sorry, I only gave you a selection. But the
yeah,
initial
got it.
one was like they selected it. They selected it, sorry. I mean they started out with, the whole vascular tree, and then they selected it to the left.
And how did they think it developed?
Oh, I don't know. That's a
Because
good
usually we think
question.
about trauma or
The
biopsy.
patient had, well, let's see, there's not a transplant biopsy. So maybe in like post-surgical, could it? I don't know.
Yeah, maybe there was like some trauma during the transplant.
Yeah, exactly. Could that be?
So this elderly gentleman has this lump in the anterior abdominal wall.
Patient, are they diabetic?
Yes.
Yeah,
That's like
it's
the
like
breast sign, right?
lipodystrophy.
Yeah, from insulin injection.
Yeah. I mean, I've seen, but I've never seen like this impressive. So like real bulges, and then that's the glucometer.
Yeah, there's a specific lipo name for this, right?
Lipohypertrophy because of insulin.
Yeah, lipohypertrophy.
So what happens is each time, if we give any other injections also in the anterior abdominal wall, we end up having this soft tissue granuloma. Insulin is an anabolic hormone. So insulin causes like increased fatty deposition. So that's why there's fat as well as this soft tissue component, and it looks like breast. So like if it's a female patient, we can very well think of another differential if the patient is not on insulin as like accessory nipple or accessory breast tissue along the milk line, mammary line. But this patient was a male. That's about it for the first case.
Cool. Okay, so this person's hemoglobin was low. So we did a CTA, a little grainy, I'm sorry, but couple of things. First of all, what do you guys think about this uterus? This is the uterus here. Scroll through.
Gravid uterus. Okay.
Yeah, so it's a postpartum uterus. Excellent. So it looks large and boggy and hypervascular. There was some blood products in the endometrial cavity. There was even some blood products in the expanded vagina here. But the other thing that was not known before they gave birth was that there was a large lesion here in the right adnexa and possibly in the left adnexa as well. There was an MRI that was done, and this is what it looked like.
Oh, wow.
The MRI. So there's that mass. This is the uterus, the gravid uterus, or the immediate postpartum uterus. And there was also something in the left ovary here. So we start thinking about our solid ovarian masses. Here, I'll show you. This is the post contrast, so definitely enhancing bilateral adnexal masses. So when we think about solid masses, like the best thing would be a fibroma, fibrothecoma, but those are usually much darker, like as dark as muscle, because they're very fibrous. So this is a little bit more malignant looking. It's got more of the evil gray. It's definitely enhancing. So we also think about metastatic disease because, bilateral solid could be from colon cancer, could be from gastric cancer. Krukenberg tumors are usually signet ring cell. Anyway, these were resected, and turns out these were bilateral Sertoli-Leydig cell tumors. So just a couple of things about Sertoli-Leydig cell tumors. I'm just going to pull up the Radiopedia article. A lot of them are androgenic, so they get virilization. So a lot of patients will have virilization. A small subset is hyperestrogenic. And then this part I didn't know that there's different subtypes. Most of them are well differentiated, and most are unilateral. However, they can be intermediate and poorly differentiated. In our patient, there was bilateral tumors, and the large one was actually poorly differentiated. Those have a worse prognosis. So this was just a sort of like surprise incidental mass postpartum, and turned out to be Sertoli-Leydig cell tumors, which is one of the less known solid tumors of the ovary that causes androgenous virilization.
So this is the rectal MR sagittal view for this patient, and we see that there is rectal tumor. The patient was given neoadjuvant therapy, and then subsequently APR was done. And then I have a scan after the surgical treatment. And we see, what do we see here?
It's like thickening.
Exactly.
Yeah.
Wait, was there a flap?
Perfect, yes.
Yeah, there's a muscular flap that they flipped.
Oh, the
from
medial.
Yeah, the thigh into the pelvis.
So the medialmost muscle is Gracilis, and that's the muscle which is twisted over itself, like, and then it is sent to the made a tunnel and then put into the perineum. It's better seen on coronal. So that's the muscle going into the perineum, and that's the subcutaneous soft tissue in which there was tunneling, and then the muscle flap is inverted over itself and then just sent to the perineum.
Yeah, so when they do APR, sometimes they'll do like an omental pedicle flap, like a fatty flap that they put into the pelvis, and then other times they'll do a muscular flap that they put into the pelvis.
And I have a picture from
And if they're not well vascularized, they can become ischemic.
Yes. And I have an internet picture for us. So that's how our case looks like, that the muscle is inverted and sent to the perineum, the gracilis flap.
Cool. Yeah, I never like understood why they did these flaps, but one of the reasons is to just kind of take up, like, be space occupying so things don't fall down there, and the other is that it actually promotes healing.
Yes.
Cool.
This is a patient with history of cervical cancer. They got the MR for local staging, and then here's the cervical, the cancer here, anterior lip of the cervix, and it measured just under 2 centimeters. And so I gave a report. Let me just stop share. Okay, yeah, here we go. Let me share again. And then our gynoc asked me about stromal invasion. And so I had to look it up because that's not something that we typically report. So then I had to measure kind of like the invasion or the depth of invasion. So let me share a screen, PowerPoint that I created. Okay, can you see my screen?
Yes.
So I had to look this up just to try to understand, because they said that it'll change the surgical approach depending on this like extent of stromal invasion. So the cervical anatomy, you got the fluid, the mucosa, and then there's the stroma. And the stroma, there's 2 parts to the stroma. There's the glandular stroma, the kind of the T2 bright fluidy stuff, and then the fibromuscular stroma, this gray area. And so what they wanted to know was how much of an extension or invasion there is into the stroma. So the patient was youngish, but the stroma can look different depending on the age. So in younger patients who are premenopausal, that you get more kind of hyperintensity of the glandular stroma, but postmenopausal patient, they all become kind of dark. So it does change with menopause. So the staging, it's actually not the stromal depth is not part of the staging for cervical cancer, but the invasion into the stroma predicts they become high risk. They become high risk. So the more, so it says 1 centimeter or more invasion has marked increased chance of recurrence and death from cervical cancer. And then in terms of our reporting, like we measure the maximum craniocaudal dimension, and if it's like, this was kind of borderline at like 1.92 centimeters, but if it's small, they can actually do fertility sparing. So they do like a cold knife resection, which is what this is. So they cut it out cold, like with a knife. They can also do cautery, but with malignancy, they do cold knife so that they can get margins, microscopic assessment of the margins. So going back, so deep stromal invasion. So early is if it's 5 to 7, but if it's like 10 millimeters or more, then they become high risk. So this was, since the patient was borderline for fertility sparing, this was a marker that the gyn-onc was using to assess kind of their risk for whether they should proceed with a like a total hysterectomy or, you know, do a fertility sparing resection. So the stromal invasion though is the pathologic. It's typically pathologic. It's not something that we provide by MR. So I thought it was a kind of a unique approach, you know, ask from our gyn-oncs. And I think just again, you know, to risk stratify the patient. But because the depth of the invasion was like 5, like actually 6 or 7 millimeters. And the other thing they use is if it's a third invasion, like a middle or outer third. So the deeper the invasion, you know, the higher the risk. So this would probably classify as like a third of an invasion into the stroma. So the patient actually, after they did a cold knife, and then after that, they ended up actually getting a hysterectomy, and there was no residual cancer in the hysterectomy surgical specimen.
Cool. So in this case, did you tell them, I think that this is less than 10 millimeters?
Well, I gave them the depth of invasion.
What did you give them as the depth? Like where?
Oh, so I gave them a depth of 5 millimeters.
Because you kind of like pushed a line down from where the.
Yes. So
Okay.
I took basically like the length of the cervix. So they can do a qualitative where it's just like the first third, middle third, or the outer third, or you can give a measurement. To me, I was new to this because I've never reported cervical stromal invasion before, so I had to understand like what the rationale was clinically, because this is something that pathologists provide, not radiologists. And it was,
Right. But in this case, did you kind of draw a line vertically down from like where you thought
no.
the surface was and then go depth and then go deep to that?
Oh, so I
Yeah.
I had already reported the craniocaudal margin and like the thickness, and so the question now is the depth of invasion. So then I basically drew a line from the mucosa or where the mucosa would be to here,
Yep.
and then gave the measurement from the where the mucosa would be into the invasion, and then so I gave a quantitative number, but it came out to be like a third or 2/3 into the less than 50%. Yeah.
This is
It was
interesting.
really hard. It was a really hard case for me. So I'm sharing this just to give you the background understanding of what I learned from trying to figure this case out.
No, it's great. It's also a rare case because I've never seen one like that was this small in a way, you know, like that it really was only invading only 10 millimeters. So I could see how you could do it in this case, but like most of the cases that I have, they're not like that's not even the question, right? It's like it, you know, it's not
It's
like
like, yeah, is there perimetrial invasion or not, right?
exactly.
Like,
Yeah.
is it surgical or non-surgical?
And
Yeah,
it
and
makes
this is
sense
an
because
early.
I never understood how they did fertility sparing because I was like, what? How is that possible? You know, so that makes sense. Like if it's below a certain size and depth, they could laser it out, spare fertility, and then go from there.
Right, right, exactly. Yeah. So it was a lot of good learning.
Okay. So scrolling down, you don't already see that the esophagus is distended with fluid. Somebody's chatting in. Let's see. Oh, okay, Nelly said she'll be right back. What do you think, Yashant?
Organoaxial position of the stomach.
Okay, that's a thought. So you're saying like there's a hernia with a
Yeah, let's see on coroner that will be.
yeah, hold on, let me just take off. Okay. Okay, so that was the initial thought. Like, it's like a hernia with a obstruction. However, I'll tell you that's not what it was.
Okay.
So anyway, the fluid is like the fluid-filled esophagus is going down, and then this doesn't really look like a hernia, right? Like it's there's something like a little funny about it. Like there's this little gap. So anyway, this was a Toupet funduplication. There was an obstruction. So there was like a herniation of the funduplication, and then an obstruction of the esophagus, so that the fluid was like preferentially going into the wrap.
Oh, wow.
Yeah. So they ended up resecting it, but let me just show you, and fixing it. But let me just show you. This is just an example of the different types of funduplication. So the most common type is a Nissen, where you take the proximal stomach, wrap it around, sew it together. There's a couple of other ones, but the Toupet is like a partial wrap. So you don't take it all the way around and sew it together. You actually just sew it to the distal esophagus. Here it says like one of the advantages is that there's less dysphagia afterwards. So it's less tight. However, that there can be a less effective barrier to reflux. But I also think that in this particular case, there was also a hernia. So even though it was less tight in general, because it had herniated up, it actually caused an obstruction.
Yes. Nice case.
Yeah. Go.
So sometimes when there is postpartum hemorrhage, they put in a device called JADA device. So the bladder is here and it has Foley's, it is compressed. So this is not Foley's, this is inside the cervix and uterus. And the balloon of JADA device, JADA, is inflated. And I'll show you the internet picture how it looks like. So it's a loop at the ahead of this bulb, and then it has suction. So it can just suction and then let the uterus collapse so that the endometrium is opposed to itself, and then the bleeding is stopped. I can show it in other planes. So it's like a loop at the tip, goes to a balloon or a bulb, and then inferiorly. Let me pull out the internet image.
I was going to say, is that where the balloon is supposed to be?
Yeah.
At the cervical, in the cervix.
Yes.
Got it.
So that's the balloon area. That's the intrauterine loop, and it has vacuum, and then it is attached to the vacuum, and then the uterus basically, because of that shear effect of vacuum, just all the walls oppose each other, and then the bleeding stops.
Got it. Because there's something called a uterine balloon, right? That they'll inflate an entire balloon in the uterus. But you're saying that vacuum might be more effective than
Yes.
actually putting the balloon in the uterus itself.
Yes.
Got it. I remember this from my global health days where they were saying like postpartum bleeding is a major issue in like, around the world. And that every midwife or anybody doing delivery should have a balloon with them. to start to stop postpartum hemorrhage, because like it's a really basic tool that you could use anywhere in the field, and help women who are having postpartum hemorrhage. And it's pretty inexpensive. I don't know about this particular the Jada one that you're talking about, but I know that uterine balloon has been used all over the world. So
interestingly, Jada got FDA approved only in 2022, and then you also need vacuum. So I don't know how practical it will be for field purposes.
Got it. Yeah.
I can run this video if you like.
And the connector at the end. Data provides definitive, visible, and observable control of hemorrhage and bleeding. The JADA system demonstrated effectiveness in controlling abnormal postpartum bleeding fast in a median of 3 minutes. JADA is made of soft silicone and is easy to use. The intrauterine loop evacuates blood from the uterus. The cervical seal holds a vacuum within the uterus, and a connector at the end of the tube attaches JADA to a regulated vacuum source. Upon observation of bleeding, evaluate the patient for lacerations, retained products of conception, or other causes of excessive force. Do not grasp JADA with an instrument transvaginally, gently guiding the intrauterine loop into the uterus and ensuring that it is oriented to the frontal plane of the body, with the seal valve oriented at 3 or 9 o'clock. Ultrasound may be used to confirm proper placement of the intrauterine loop within the uterus. After insertion, confirm that the intrauterine loop is entirely within the uterus and the cervical seal is at the external cervical os. Attach the pre-filled syringe to the seal port and
Okay.
Cool. Thank you. I wanted to show you just one thing. Oh, this is my next case, but I wanted to show you this, which is what I was talking about, like the low-cost uterine balloon tamponade for postpartum hemorrhage. And this is just like one random article about it, but yeah, you can use it in any kind of setting, and it has the potential to save a lot of lives. So
Okay.
yeah. Let me stop sharing. So this was a VCUG in a patient who had had a lot of pelvic trauma. You can see that they have this lumbosacral fixation and a urethral injury. And it was pretty bad. So they did a suprapubic catheter for about 6 months. And then we're injecting the suprapubic catheter and doing a VCUG. So here we are filling, and then now we started excreting. And you can see that we're like in this AP view, we're not really laying the penile shaft out and the urethra out. So we put them in a different position, and now we can see, and I usually do rapids. So we filled the bladder, and then we had the patient urinate, and we can see that basically they had fixed the urethra with a buccal mucosa, and it's irregular, but and it's a little bit narrowed here. But pretty good, and he was able to urinate. And so this is the kind of, and actually this is the penile urethra, bulbar, this is the membranous urethra, and the prostatic. And this is actually like where often a lot of the injuries happen, which is at the border of the membranous and the prostatic urethra, where you have this shearing from the like fixed membranous urethra, which is in the muscle, as well as the prostatic urethra, which is in this dense prostate. And it gets sheared right here and can be disrupted, and that's where it needs to be fixed.
Oh, cool.
Yeah. So this is
I would have called it as filling defect.
Yeah, I mean, it's not normal, but it's for post-op, this is actually pretty good luck.
Okay.
Yeah. Yeah, and it is a little irregular. I can see what you're saying, like filling defect here, but most, it's kind of just the irregularity there. It's actually really difficult to reconstruct these.
Yeah, I wonder, like, the space is so limited there.
Yeah. Yeah, so this actually
Space is so limited. Oh yeah, they take the mucosa of your buccal mucosa, and then they could do like multi-stage reconstruction depending on the length.
Exactly. And they have to wait, like they have to put the suprapubic tube in for like 6 months before everything else heals, and then they'll go back and reconstruct the urethra. And when I was presenting this to my group, somebody said they recently saw a case where there was squamous cell of the buccal mucosa graft, which makes sense because, like, it's skin or squamous epithelium, which you can get anywhere along your distal urethra as well. But anyway, that is one of the risks.
Then I have a case. This is a patient who had had no prior imaging. I had an imaging on ultrasound that showed this hepatic lesion, and so we got an MR to figure out what this was. So here it is. So there's your T2. Here's your diffusion right there. And then we do the dynamics.
On the T2, it was kind of dark.
It's here.
Bright and dark, no?
Bright and dark. So centrally dark, and then kind of peripherally hyper intense.
Okay, and then on
we don't have CT.
On the diffusion, it's not really restricting, it's like shining through.
Oh, correct. Yeah.
Okay.
This one, I think it's just, I don't know if there's a calcification or what, because it's like a susceptibility dark, kind of dark, not a T2 dark, fibrous dark look. And then here is your dynamics. So here's your arterial subtraction. And here is, I think, 90 seconds. Subtraction.
Sclerostomangioma.
Now, would you just call it straight up sclerostomangioma, or would you give a differential? Like, would you say no, biopsy is not needed if we don't have any priors?
I was going to say I would look for priors. I try to hide.
There's no priors
at any cost. I would say it's in the differential. They have no liver disease, right? No background liver disease.
Let me see, primary biliary cirrhosis.
Oh. Ooh. I mean, it could be a cholangio. So I think no, I could not.
Biopsy.
I could not just say sclerostomangioma. Yeah.
Okay, good. Good. So we gave a differential, and biopsy was indeed sclerostomangioma.
Nice.
Yeah. So the teaching point is you can't
really
if you don't have priors.
The really dark part, like it can have calcification or it can have a lot of fibrosis.
For sclerostomangioma?
Yep.
Okay, yeah. And I was watching an old video because I was looking for another case, and one of the other in the old video you had also mentioned because I had shown a case of a sclerosing hemangioma, which is different from a sclerostomangioma. With the sclerosing hemangioma, you can have involution and all these changes because it's sclerosing, whereas in a sclerostomangioma, it's already completely kind of involuted and sclerosed, so it's going to look different.
Yeah, exactly. So sclerosed is like already fibrotic. In your case had like capsular retraction, delayed enhancement. Those all overlap with cholangio. But the one clue for sclerostomangioma is it has like really dark parts and then some bright parts. If it has like really bright parts and really dark parts, that's very suggestive to me of a sclerostomangioma, because like our sclerosing one, because the really bright parts are like the prior hemangioma. And then the really dark parts of the really fibrotic areas. And yeah, as it's sclerosing, like on its way, you might see areas where there's the delayed enhancing fibrosis, but also areas of globular enhancement. So it's like a mixed picture of like a hemangioma with like a more fibrotic lesion. When it's completely sclerosed, it might just look fibrotic. So diagnosis of exclusion, but I've seen a lot of them now. So I do think that
You're a pro.
No, I just think that we underdiagnose them. So.
Okay, my next case is a prostate cancer case. So the patient had a grade group 2 prostate lesion. It was right here. The diffusion, it was an outside diffusion, but I think it's still diagnostic. It's this little guy here. It restricts right there. Okay, so and then it was biopsy proving grade group 2. So Gleason 3 plus 4.
Hold on. Your T2 thing looks bigger than this
No,
diffusion.
here,
Can you
let's see.
move your
It's right
80?
here. Sorry.
Oh, I see.
The marker was on a different ROI, but this is the lesion that turned out to be
Got it.
grade group 2. Okay. And so the patient went on to this procedure. It's a and that's what the case is about, is this procedure. It's called Vapor. Here, this is the link to that company. Vapor 2 trial. And they have a current clinical trial going on. And so what they do is they put this little catheter, and it's like vapor. It's like water vapor. And they kill the tumor. And here's like MRI findings of post-vaporized prostate. So it's really interesting because, well, this is the lesion, but like I've noticed like the fluid kind of separates the transition zone and peripheral zone, like in a really interesting way. See that? Like,
Yeah, is that what you're expecting to find post vapor, or like what?
well, I don't think we know what to find post vapor, but this is something that we're observing.
Okay, this
and
is really dumb, but do you get vapor from heating, or is it a different process?
I don't know how they vaporize the water. It has to be some kind of heating mechanism. I don't know if it's from like heat, like what kind of heat, there's so many different ways to deliver heat.
Got it. But the end result is not called an ablation. It's called a vaporizing.
Oh, I think it would probably still fall under the ablation umbrella, like with HIFU, microwave, or cryo,
Got
I
it.
think. I don't know for sure. I don't know if it's both, but this is just another, minimally invasive percutaneous offering for management of low risk prostate cancer. So I'm going to show you another case that it also underwent vapor. And to show you that it has a interesting but kind of similar imaging post-treatment changes. Okay, can you see?
Yes.
So this one, you can really see the like separation between the transition zone and the treated. Both were non-viable post-treatment. There's like scarring and stuff like that, but the post-ablation like fluid separation between the transition zone and peripheral zone is something that
That's very different than the ablations that I've seen.
For vapor or
No. I mean for like regular other kinds of ablation.
oh yeah, exactly, yeah. And I want to highlight that like pathologists, they like they can't separate a peripheral zone from transition zone. Like for them, it looks all similar apparently. But by MR, they look very different. They have very different signal characteristics. And the separation of these two zones on MR suggests it's actually like two separate zones, right? Because you can see this kind of potential space that now is being separated, like with these vapor catheters, the fluid at least.
Very cool.
So another patient with Gracilis flap, this is better seen. We have MR. So the muscle is inverted.
Oh yeah.
Very
so
nice.
Yeah, that's the
Beautiful.
tunnel I was talking about. Sorry, I did not find this in the first go. I should have shown this before and the other case later.
Just highlights how beautiful like MR is, to really the anatomy.
Yeah, and I'll just show it on CT as well.
Nice. It also shows you how much we don't really need our gracilis muscle.
Yeah.
This is a congenital finding. It says patient T2, and then the T1 is here.
Wait, what organ are we focusing on?
Pancreas, I'm sorry.
Oh, okay, I
Pancreas.
was like, I see stuff in the
Pancreas.
kidneys. I see.
Yeah,
Wait,
sorry.
wait. Mm.
This is a pancreatic cyst surveillance MRCP.
Oh, wait,
So
it's missing half the pancreas, like
yes, yes,
truncating the
yes,
pancreas?
Dorsal
yes.
pancreatic agenesis.
Sorry, what did you say,
DPA,
Yashant?
dorsal pancreatic agenesis.
Yes, so that's exactly right. So congenital finding, this is dorsal agenesis of the pancreas. So there's two segments. There's the dorsal here, that's the bigger chunk that's developed congenitally, and there's a ventral. And then eventually they fuse. And then the dominant duct, it becomes this, but sometimes you can have a persistent accessory duct. But in this case, the dorsal pancreas is just never developed. So that's why we only see like the pancreatic head, the ventral pancreas.
In fact, like, you always need MR to differentiate it, because on CT, it can be just atrophy of one half of the pancreas, and it is also associated with other abnormalities in females, including reproductive system abnormalities like uterine anomalies.
Good to know.
I've also seen cases where like there's like polysplenia, azygos continuation, and dorsal agenesis, or like truncated pancreas, not necessarily complete agenesis. Cool. By the way, also you only need like 25% of your islet cells to have enough insulin to not be diabetic. So that's why like you can do a Whipple or distal pancreatectomy and you're okay, but they really don't want to do a total pancreatectomy, because you become a brittle diabetic, because you're not only like not making insulin, but you're also not making glucagon. So you're not like releasing glucose when you need it as well.
Nice to know.
Okay, left-sided abdominal pain.
Some mass-like tissue around the colon.
It's like some perforation.
Okay, so you're seeing some free air. This is actually small bowel here. So we have some thickened small bowel. We have mesenteric stranding. We have some air outside of the lumen. So I was like, okay, this makes sense. This is why the patient's having left-sided abdominal pain, but it was very localized. So it felt like a very localized enteritis. The vessels were all open. They didn't have other kind of like bad vascular disease.
They eat something?
They did not, it was not like a perforated like fishbone or anything like that. Good thought. But one of my colleagues, what did you say?
Oh. Sometimes they can have jejunal diverticulitis. Like,
yeah, that's exactly what we thought this was. So you see here where one of the pockets is more rounded and it looks like a tick.
yeah.
So I thought that this was a tick and that there was like a micro perforation, leading to like some air kind of coming into this area and all of this inflammation.
And was there any other areas of diverticuli?
There was not. No. I know
interesting.
sometimes it can be like lots of
Multifocal.
diverticula, but no, we did not see any others.
Does
But
this
they were just
patient have
treated
any-
conservatively and they did great.
Does this patient have any connective tissue disorder? Like, especially when we have wide mouth, small bowel, not duodenum, jejunal or ileal diverticula, think of connective tissue disorders like scleroderma, rheumatoid arthritis.
Okay, they did not have that. This was like a pretty healthy patient. I also don't see like the dilated bowel, like the hidebound bowel and stuff like that, but good thought.
We can think that. Okay, so this is like just the splenic findings.
Calcifications.
Old granulomatous disease.
That's a very good thought, but these calcifications are pretty regular, right? The entire spleen is gone. Yes, there can be differential old granulomatous disease, silicosis. This patient was SLE, and this is very typical of SLE spleen. I did not know until very recently. And so this patient is silicosis, and that's because of silicosis, but it can also occur in SLE. And I'm pulling
Okay, two questions. You said What is it about the calcifications? They're not just rounded, they're irregular?
They're not very random. They're pretty regular, and the entire screen is like even
Oh,
like with granulomatous, we see it pretty random. They're like very uniformly distributed. So this is silicosis. This can also be SLE.
and is it a vascular calcification or what's the?
I don't think I know the cause for the calcification.
Okay. It says periarterial fibrosis suggesting vasculitis in your little thing down there.
So there must be perivascular calcification. That's why
Yeah,
they are so
opinions, yeah. Cool. Okay, thanks, guys.
Okay.